Chapter 5 is going to cover and discuss some of the genetic and congenital disorders. Just a couple things about how we will approach and cover this material. One is that, again, the information from Chapter 4, and I think I mentioned this in the previous presentation, but the information from Chapter 4 is really foundational to a lot of the understanding of the information in Chapter 5. There will be some, I think, repetition of some of the information that you might hear, but we're going to take the information maybe a step further and try to apply it to some of the specific genetic disorders. But having mentioned the genetic disorders, I'll also say that I don't have a specific unit learning outcome of understanding or being able to describe a lot of the genetic disorders. So you'll find in your reading that there are more in-depth discussions of several of them, like things like Marfan syndrome and Down syndrome and Klinefelter syndrome, cleft lip. I will not be, there's no ULO specific to those disorders, like nothing that says understand and describe the clinical manifestations of Downs or Klinefelters or things like that. And I'm not going to necessarily go into them here. More my focus with this, again, is going to really be sort of understanding the different types of genetic disorders as far as, what causes them, and really understanding how you would help a patient maybe understand their own risk profile regarding those things, understanding some of the genetic transmission of some of these pieces, again, more focused on patient education, and then also understanding some of the diagnostic tests and procedures that go along with um, genetic disorders and counseling. So we're really going to focus our attention there. Okay. All right, so just some terminology, and we've talked about some of these already, but just to reiterate, there are a lot of terms here that we're going to sort of use over and over again. We've used already, but just to make sure you're familiar with them because they'll pop up in test questions. We'll talk in these terms. So just to go over them, so the term congenital. So congenital defects, we sometimes call those birth defects. Those are abnormalities of a body's structure, function, or metabolism that are present at birth. Two members of a gene pair, one that's inherited from the mother and the other from the father, are called alleles. And remember that the genes on each chromosome are arranged in a strict order, with each gene occupying a specific location or locus. So that's gene locus. Okay. The genetic composition of a person is called their genotype. So that's what is written in their genes. And the phenotype refers to any observable expression of that genotype. So that's things like physical traits, biochemical traits, whether it's the presence of a specific disorder and what that looks like. Okay. Remember, homozygous refers to members of a gene pair that are identical or that code the exact same gene product. Okay. And if those two members of the gene pair are different or code for different things, then those are heterozygous. Okay. Let's see, many genes have more than one normal allele, so there's alternate forms of a specific allele that might be considered normal and that appear at the same locus. That's called polymorphism, and there can be a wide variation in gene, what we call penetrance and expression. So sometimes people inherit what we would consider a dominant mutant gene, but the phenotype, or what is displayed, even though that's a dominant gene, is variable because there's different levels of penetrance of that disorder and different expression of those genes. So this really gets at, we'll talk about this again in a bit, but this really gets at the fact that just because someone has maybe an autosomal dominant disorder and they have that autosomal dominant gene, their expression of the disorder associated with that autosomal dominant gene may look very different than another person with the same genetic disorder, again, because of things like penetrance, gene penetrance, and gene expression. Okay. All right. So what causes congenital or birth defects? So sometimes they're genetic factors. So it might be single gene inheritance or multifactorial inheritance. It might be aberrations to chromosomes themselves, whether it's deletions or additions to the structure, whether it's a completely missing portion of or missing chromosome, if it's an additional chromosome, and we're going to talk about kind of all those genetic factors in this presentation. Birth defects can also be caused by environmental factors that are present during fetal development. So we'll talk about these as well. So things like maternal diseases, things like infections, drugs taken during pregnancy. We'll talk about kind of the effects of things like alcohol, vitamin A. We'll talk about some deficiencies of certain vitamins that can cause these environmental factors that impact fetal development. And the final thing that can cause birth defects are intrauterine factors. These are a bit more rare than the other two, but sometimes it's caused by things like fetal crowding during multiple birth, fetal positioning, entanglement of fetal parts. So these are things that happen in utero that can cause congenital problems. So we're going to start with our discussion of some of the genetic causes of congenital disorders with a discussion of the characteristics of a single gene disorder. So if we're going back to kind of our foundational discussion from chapter 4, these are the types of genetic conditions, diseases that can be followed using some of those Mendelian properties of genetic inheritance. So these are caused by a single defect or single mutant gene. They can be present on autosomal chromosomes or on the X chromosome. We'll talk about the reason why I don't list the Y chromosome there momentarily. They may affect one member or both members of an autosomal gene pair. So you can see those defects on one member of the gene pair or sometimes on both. Again, they follow those Mendelian patterns of inheritance, and they're characterized by their patterns of transmission. So you can look back through obtaining a good family genetic history and really trace these single gene disorders back through that kind of family pedigree. These are the most predictable type of genetic disorder in relationship to their patterns of inheritance. So when someone has a single gene disorder, these things are usually what we see happening in the body due to single gene disorders. These changes are what cause the phenotypes or what's displayed, the clinical manifestations, the way the disease displays itself. So usually, in the vast majority, virtually all of our single gene disorders fall into this first category. There's a formation of some abnormal protein or decreased production of some gene product. We may also have defective or decreased amounts of a certain enzyme. There may be defects in receptor proteins and their function. There might be alterations in non-enzyme proteins, or sometimes genetic mutations result in unusual reactions to medications that we get, or reactions to drugs. So those are the most common, or those are the types of problems we see with single gene disorders. All right, so let's talk about the different types of disorders that we see under this umbrella of single gene inheritance. So we'll start with autosomal dominant disorders. So these have a single mutant allele from an affected parent, which is transmitted to an offspring regardless of their sex. So if we see that something is autosomal, the inheritance through the pedigree will be the same regardless of whether or not offspring are male or female. That will change when we get to some of the disorders that are passed via the X chromosome, but for now it's not at all linked to sex. So what you see here in the picture is just a simple pedigree for inheritance of an autosomal dominant trait. The squares are men or males, the circles are females. And if the circle is shaded in, as you see here, that represents an affected parent with the mutant gene. So in this pedigree, the female is affected with the mutant gene, so has that autosomal dominant trait that is displaying itself, right? An affected parent with an autosomal dominant trait, as we see here, has a 50% chance of passing that mutant gene on to each child regardless of sex. So you can kind of see that here. So male-female pair, we have 1, 2, 3, 4 offspring, and we have 2 that have that disorder. Okay, so you see that 50%. Unaffected relatives of the parent or unaffected siblings of the offspring do not transmit the disorder. So if you look here at this first degree, right, these 2 offspring, female, male offspring, are unaffected. They do not display this disorder, so they will not pass that disorder to any offspring. Okay. A lot of the time, in many of these kind of autosomal dominant conditions, what we see is delayed age of onset. So many of these autosomal dominant disorders don't display themselves signs and symptom wise until maybe later in life. The other thing we'll say is that even though there's a 50% chance of inheriting a dominant genetic disorder from an affected parent, there can be a wide variation in gene penetrance and expression here. So when a person inherits a dominant gene, they may fail to exhibit the associated phenotype because that trait that gene codes for has reduced penetrance. And there's a lot of autosomal dominant disorders that don't display themselves in phenotypes because of that decreased penetrance. Okay. And that's something that might be important, as far as genetic counseling, education, and things to discuss with parents as well, is that not all affected individuals display a disorder in the same way. Things can range from very mild cases of something to much more severe, depending on that penetrance. Okay. So just some examples of some autosomal dominant single gene disorders that we're going to actually cover or maybe talk about in this class. One is adult polycystic kidney disease, which we'll talk about when we get to our section on renal disorders. We'll talk about Huntington's disease and some of our neuro units. And we'll talk about something called osteogenesis imperfecta when we get to the musculoskeletal discussions, all disorders that are passed in an autosomal dominant fashion. So the next type is autosomal recessive disorders. And so these are manifested only when both members of the gene pair are affected. So both parents may be unaffected, but they may still be carriers, right? So if both parents are heterozygous and they're both carriers of this autosomal recessive, can still pass that disorder, but only those who are homozygous for this autosomal recessive mutation will actually display the disorder. Okay. So here's another sample pedigree for inheritance of an autosomal recessive trait. Again, the squares represent males, circles represent females. When the symbols are half shaded, that means that that parent is a carrier of an autosomal recessive trait. So when you are a carrier, you do not display the trait, but you do carry that mutant gene, and in this case, it's recessive. So these are probably heterozygous, right? One dominant, one recessive, so the recessive doesn't display itself, okay? But both carriers both parents were again carriers of that recessive trait. When both parents are carriers, as you see here, with each conception or each child, there's a 25% chance of having an affected child. So when you look at this pedigree, a full shaded circle or square is an affected child. So if we look here, we see that, right? 1, 2, 3, 4 children. We have one of the 4, 25% affected. And so they would be genotype-wise homozygous for that autosomal recessive trait. Okay. We also have a 50% chance of children being a carrier. And so we see that here, one male, one female carrier. So again, these are probably heterozygous, right? And we have another 25% chance of a completely non-affected and also non-carrier child. And all of these things, again, are regardless of sex because these are autosomal in nature. Okay. Some other notes that I'll say about autosomal recessive disorders. The age of onset for these is frequently much earlier in life when compared to my autosomal dominance. Um, some examples of disorders that are carried this way are cystic fibrosis and sickle cell, and those are some autosomal recessive disorders that we'll talk about in this class. Okay. And the final pedigree we're going to look at is a sample pedigree for inheritance of an X-linked recessive trait. So X-linked recessive traits are expressed phenotypically usually in the male offspring, whereas females are typically just carriers for the trait. So when we think about the X and Y chromosome, the Y chromosome, remembering that males are XY, the Y chromosome carries very little genetic information. So most of the genetic information that is displayed from the sex chromosomes in men is coming from the X chromosome. In females, because there's two X chromosomes, both with full genetic information, if there's mutations to one of the X chromosomes and we have one functioning or normal X chromosome, it usually sort of covers or masks is the dominant phenotypical display is coming from that normal X. Or again, in a male offspring, because that Y has very little genetic material to kind of cover up, right? The X, I always think about this like if you overlay an X over Y, it's going to cover basically the whole chromosome, right? Um, um, so there's just much less genetic information coming from that Y. So again, what you see there because of that and the way that that genetic information is carried is that females don't tend to show the phenotypical traits, whereas male offspring will. All right, so let's look at this individual pedigree. So again, this is for single gene inheritance disorders with X-linked recessive. So these are always X-linked recessive. There's no dominant piece here, again, because they're sex chromosomes and because of the difference between X and Y, we just think about them as X-linked recessive. So these are always associated with X chromosome, and the inheritance pattern is predominantly recessive, okay? So a small shaded circle, like we see here, represents a carrier female. And the larger shaded square right here is the affected male. So a carrier female, you see here, will transmit her carrier status to 50% of her daughters, and 50% of her sons will be affected because if they get the mutated X, they'll display the disease. Okay. So in this case, again, yeah, we see here a male offspring who displays the disease because this male offspring inherited the X chromosome from his mother that was mutated. This male offspring also inherited an X chromosome from his mother, but it was the non-mutated. So this male is not affected by that trait at all. This female received the mutant X, but probably doesn't display anything because she also received one normal. And this individual was not affected, only received the non-mutated X. Okay. If we look further down the genetic line, so our affected male passes that mutant gene to all of his daughters, so all daughters will be carriers. But the affected male will have no affected sons because they do not pass X chromosomes where the defect occurs. So they pass down the Y chromosome to create male offspring, and so they're just getting the X chromosome of unaffected. So they just pass on carrier status. They do not pass on being affected. Okay. So, oh, I have an example. One example of things that are passed this way is color blindness. So color blindness is an example of an X-linked recessive disorder. We see it almost entirely in male offspring, which follows with this pattern of inheritance. Right? So those were our single genes. So now we're going to talk about and contrast that a bit with characteristics of these multifactorial inheritance disorders. So remembering back to our previous discussion that these are caused by mutations on multiple genes in multiple locations and combined with environmental factors. So we don't always know the exact number of genes. We're not always clear cut on what those environmental factors are. We just know that both of them are required for that genetic mutation to display itself phenotypically as a disorder, right? So I think the example we used previously was diabetes. We know that there's a genetic link, that there are genetic mutations that cause diabetes, but not everybody with those genetic mutations displays diabetes because there's probably also an environmental influence, whether it's a virus, something else that sort of turns on that disorder at the genetic level. Okay. Prediction is not clear cut here because those characteristic patterns, the prediction isn't clear cut because we don't have those same characteristic patterns as other congenital disorders. Multifactorial congenital malformations tend to involve a single organ or tissue derived from the same embryonic developmental field. So that's a little different than our single gene mutations that usually display themselves in some kind of malformation or of proteins in general. So that, again, a bit of a difference here. So these traits don't follow a clear-cut pattern of inheritance. Disorders can be expressed during fetal life. They might be present at birth. They might be expressed later in life. So where these things show up is really variable. And again, that phenotype is dependent on both environmental change and genetic mutations. But another thing to understand about these is that the risk of recurrence of these disorders in future pregnancies is high for the same or similar defect. So if you have an offspring that is born with one of these multifactorial inheritance disorders, if that same mother has a second pregnancy, recurrence of that same disorder or a similar defect is much higher. So again, sibling pairs have higher chance of having the same defect. That's kind of what we're saying there. The third thing I would point out is that first-degree relatives of affected people also have an increased risk as compared to the general population of having a child with that disease. So this is one of the reasons why, right, that we take good family histories from people as well. Because if you are a person who had a parent or a grandparent with a certain genetic disorder, your chances of having a child with that disease also increase because of this multifactorial inheritance. So these are some examples of multifactorial inheritance disorders. There are a lot of them. This is a very small sampling. So cleft lip, clubfoot, congenital dislocation of hips, congenital heart disease, pyloric stenosis, urinary tract malformation. There are a lot more. I'm not going to require you to remember every single one. The one that the book goes into pretty frequently or at depth is this cleft lip, cleft palate. So I may use that as an exemplar of multifactorial, but you aren't going to be responsible for being able to describe and understand all the clinical manifestations of cleft lip. Okay, so moving on from those single or multifactorial genetic inheritance to some of the the congenital disorders we see, we're going to talk about the ones that arise from chromosomal disorders. So chromosomal disorders are another major category of genetic disease. One thing to understand about these disorders is they account for a large portion or proportion of early miscarriages. Many pregnancies don't go to term, a relatively high percentage of them don't. And our thinking about the reason why is that there were probably some sort of, I guess I'll use the word catastrophic chromosomal disorder that made that developing fetus really incompatible with life. So again, many of the early miscarriages that we see probably boil down to some kind of significant chromosomal disorder. These also account for some of the congenital malformations and some of the disorders of intellectual disability that we see. Okay. So more than 60 identifiable syndromes that are present at birth. So then combining that with all the early gestational loss, these do account for a lot of abnormalities that we see. So a couple different types of chromosomal disorders. Sometimes it's an alteration in chromosomal number, and sometimes it's an alternation in chromosomal structure. We call alterations in chromosomal number aneuploidy. That's the term we use. That's an abnormal number of chromosomes, remembering that you have 23 pairs, 22 autosomal, one sex pair. So anything that falls outside of that 23 pairs is considered aneuploidy. Okay. In a monosomy, you get just one of a chromosomal pair. And in polysomy, you get more than two of a chromosomal pair. Okay. These are usually caused by failure of the chromosomes to separate during meiosis. So we call that non-disjunction. Most monosomies are having only one of the pair of chromosomes. And most of our trisomies are really pretty severe. Most of our monosomies probably result in either early miscarriage, and trisomies, most of them, those infants rarely survive beyond the first year. There are, of course, exceptions. So things like trisomy 21 is Down syndrome. So that's an exception to a trisomy being incompatible with later life. Also, monosomy X is an exception to that, although monosomy X is a sex chromosome abnormality. So we'll talk about the reasons why those aren't quite as significant here in a moment. And that moment is now. So disorders of sex chromosomes are a lot more common than number disorders of autosomal chromosomes. And they're usually better tolerated, again, because that Y chromosome has very few genes on it. And then if someone is XX, all but one X chromosome is inactivated. So usually we don't see as much, issue with some of these sex chromosomal related abnormalities. So one example of this that I'd mention is this Klinefelter syndrome. So in Klinefelter syndrome, it's usually I think it's XXY. So usually males display Klinefelter syndrome with one kind of extra X chromosome. And the way that these show up phenotypically, there are men with Klinefelter syndrome who may never know that they have that genetic abnormality. They may not show any phenotypical signs. They might generally be completely unaware. And it's probably the case that there are other kind of sex-linked aneuploidies that people just live with and completely unaware unless they were, specifically karyotyped. Okay. In addition to alterations in chromosome number, we can also see aberrations or alterations in the chromosome structure. So usually these are caused by breakage of the chromosome during meiosis. So a chunk breaks, and then when it realigns itself, a portion may become deleted or rearranged, transposed. There's a lot of different ways that can rearrange itself. And then what we see as far as clinical manifestations in the offspring are usually dependent on the amount of genetic material that's either lost or displaced. So if it's a very small amount, someone may not even know they have a structural change. But if it's a big deletion or big rearrangement, these can be things that cause even early pregnancy loss if they're significant enough. So again, a wide variation in what we would see phenotypically or what it would display based on the amount of genetic material lost or deleted. Okay, so now we're going to talk about some of the environmental influences that can cause congenital disorders. So these are things that our fetus is exposed to during development. So we call any agent that produces abnormalities during embryonic or fetal development a teratogenic agent. And there is a certain time during that embryo's development when we see the most potential for disturbance of normal development, that time when the fetus is most susceptible to these teratogenic agents, and we call that time period organogenesis. And if you look at my little picture here, you can see sort of the reason why. So really between 15 to about 60 days after conception, that is when we're seeing the development of all of our kind of major organ systems. And so if During that embryonic developmental time, a teratogenic exposure takes place during one of those essential um, differentiations and developments of those specific organs. We'll see more abnormalities show up. So this is really the critical time, that 15 to 60 day window, where we really want to take care as far as things like teratogenic exposure, because that's really the most susceptible time period for a developing fetus. So when we talk about teratogenic agents, these are the three broad categories of teratogenic agents. One is radiation. We take a lot of care with radiation exposure, although probably the level of radiation that we see in things like diagnostic tests, that kind of thing, probably doesn't reach the level of anything that could cause problems with fetal development. But we still take precautions regardless. But you'd probably need a much larger dose to really have teratogenic effects from radiation. As far as chemicals and drugs really top the list of chemical teratogens. There are a lot of drugs that are suspected of causing fetal abnormalities. There are a lot of them that we once thought were safe, and now as we've used them more and more and reviewed this more critically, we're finding more drugs that probably fall into this category. So in general, and you'll talk about this in pharm as well, we really recommend that women during childbearing years, even before they know they're pregnant, avoid unnecessary use of drugs. If you're thinking back to that critical period, it's 15 to 60 days post-conception, and many women don't even know they're pregnant until, well into that time. And so if women are trying to get pregnant, aren't taking precautions against pregnancy, or of childbearing age, we would use precautions in pretty much any administration of medications for that reason. So there's also the other thing I'll say though, and again, probably talk about this in pharm, is there's always a risk benefit conversation, right? If there's a medication that is necessary for the health and well-being of the mother, living and healthy mother is also a requirement here. Those are conversations that we take, care between a woman and her physician to decide risks, benefits of continuing medications during pregnancy. As far as guidance, drugs, the FDA requires that drugs have information on pregnancy categories, and they often include things like descriptions and risks to kind of better guide that, education that we're giving to expectant parents. But some other things in this category besides drugs and medications, one is alcohol. So you see that here in fetal alcohol syndrome, and we'll talk about that a little bit more. But alcohol is a little different than some of the other teratogens because the harmful effects of alcohol are not restricted to that sensitive period of early gestation. They really extend throughout the pregnancy. So there is no safe time during pregnancy for alcohol consumption. The thing about alcohol, and I think we've talked about this before, is alcohol is lipid loving, so it easily crosses cell membranes, it easily crosses into the placenta, it diffuses itself really easily everywhere. So fetal exposure to alcohol comes very easily, even in small amounts of ingestion. So we really, with alcohol again, say that there's no safe time. We'll talk a little bit more about some folic acid deficiencies, other things that fall into this category: babies exposed to cocaine, babies exposed to mercury. And then I'll also mention this infectious agents. So we use the acronym TORCH here. So it stands for some of the infectious agents that we know can be teratogenic in nature. So it's toxoplasmosis. So that's no changing your cat's litter while pregnant. Cytomegalovirus. The O actually stands for other. The C is other, and the R is rubella, the C is cytomegalovirus, and H is herpes. So those are agents most frequently implicated in fetal abnormalities from the infectious standpoint. So a little bit more about fetal alcohol syndrome. So usually some of the things that we see with exposure to alcohol are prenatal or postnatal growth retardation, meaning low percentile weights, low percentile length. We also see a lot of CNS involvement, so a lot of neurological abnormalities, developmental delays, behavioral problems, intellectual impairments, and we see skull and brain malformations in children exposed to alcohol. So some other things that we see with fetal alcohol syndrome, there's some facial characteristics that are also pretty common. So this short, what we call palpebral fissures, which are the eye openings. We see this kind of flattened out sort of nose bridge right here. We see a kind of thin upper lip, an elongated or flattened kind of mid face, smaller chin. We might see some microcephaly, so smaller head size. So there's also some real specific facial abnormalities. So other medications during pregnancy that I'll just highlight, one is these vitamin A derivatives. These are things like Accutane that are usually used in the treatment of acne, sometimes given orally and given topically. I mentioned this one because this is one in particular that if someone is on these medications, we also require discussions of things like birth control. This is one if you're thinking about it from a risk-benefit standpoint. There are certain things, while acne is uncomfortable and upsetting for people, it's not something that we would treat with the potential for any harm to the fetus. So that's one where we would just really take precautions about discussions about birth control. Folic acid deficiency, a little different. So this is not something that we're not giving folic acid and it's causing teratogenic issues. It's the absence of it in the diet that cause teratogenic effects. So folic acid deficiency is closely associated with what we call neural tube defects. So this is anencephaly, spina bifida is probably the most common. So what we do about this is encourage folic acid supplementation during both the childbearing years, so before pregnancy even happens, and continue into the early portions of pregnancy. If you go back to my little picture that shows when the nervous system is developing in the fetus, it's really early on. It's in the first few weeks. And so that's why folic acid is important to supplement even before people become pregnant. So the final thing we'll talk about is performing genetic assessment. So these are all the different components, all the things that we include when we do genetic assessments for patients. So we assess their genetic risk and their prognosis. We get a detailed family history. We get a detailed history of previous pregnancies and any previous births, what the birth process was like. We talk about postnatal health and development of previous pregnancies. We do physical exams of any affected children of the family. And there are a lot of different laboratory tests and diagnostics we can do, and we'll talk about some of those. So why do we do this? Well, to provide parents information to be able to make informed choices about having a child with an abnormality. So if you have parents who are coming for genetic counseling who maybe have a family history of a certain genetic disorder or have a certain genetic disorder themselves, they often have a lot of questions about, what's the likelihood of having an offspring with the same genetic disorder. So a lot of the prenatal diagnosis and counseling can help with that. We can provide reassurance, reduce anxiety among high-risk groups, and let parents assess that risk early on in the pregnancy and give them assurances about the presence or absence of these disorders that we can maybe confirm with testing. So if you have someone who's really high risk for a certain disorder, we can move them forward maybe into some of the more diagnostic testing kind of aspects that we're going to talk about to further, assess risk. So these are some of the methods that we use for fetal diagnosis. So we can do some maternal blood screening. Maternal blood screening can detect various trisomies, some different chromosomal abnormalities. One common one that we might do early in pregnancy is something called a quad screen. It checks for 4 serum markers. They're called AFP, HCG, estriol, and inhibin A. Those are the 4 lab tests included in a quad screen. They give information regarding the probability that someone is carrying a child with a chromosomal abnormality. So they're not the most, I would say, specific tests. They don't generally give a definitive yes or no that a chromosomal abnormality is present, but they can strongly kind of give us a sense of the probability. And if that probability is high, we may choose to do kind of a more specific test to further look for that. Ultrasonography, very common during pregnancy. Pretty much anybody who is getting prenatal um, um, care will undergo, probably multiple ultrasounds during a pregnancy. But we can detect a lot of different defects in utero using ultrasound. So things like cardiac defects, hydrocephalus, which is literally water on the brain, things like spina bifida, which is a neural tube defect. We can look for facial defects or abnormalities. We can look for congenital heart defects, hernias, GI disorders, skeletal anomalies, lots of defects that we can potentially see or pick up on ultrasound. We also have 3D ultrasound that is even more kind of definitive and specific, especially for things like maybe facial abnormalities. So that can be very helpful and obviously non-invasive. Amniocentesis, this is an invasive test where we use a needle to draw out amniotic fluid via the abdomen. Amniocentesis is useful for those who have shown maybe elevated risk via other methods like a quad screen or on a normal ultrasound to get maybe a more specific diagnosis. But again, it's invasive and it does carry some risk. So amnio is not something that we would do for all mothers all the time, even though it's more specific. Same with chorionic villus sampling. This is an invasive procedure, but it allows us to do fetal chromosome studies, to do specific DNA analysis, looking for chromosomal abnormalities. Another is percutaneous umbilical cord blood sampling. This is also invasive. We do this typically after, I think, about 16 weeks. This has even a higher risk of complications than an amniocentesis. So we usually only do this if we need really rapid analysis. We've, kind of more like time specific concerns regarding fetal abnormalities. And percutaneous umbilical cord sampling can pick up really a wide range of defects. There's some coagulation defects that it can pick up. Wide range of potential disorders. It can look for some kind of like fetal infections. So a lot of information we can get from percutaneous umbilical cord sampling. With any of those things, amnio, chorionics, umbilical cord blood, we can do cytogenic and biochemical analysis too, look really very specifically at genetic screening.